Okay, let's talk about airway management for the pre-hospital cardiac arrest patient. Should you use a BVM with an OPA? Should you use a supraglottic airway? Or should you use an endotracheal tube? What is going to give your patient the best chance of a positive outcome? Let's talk about it. Okay, so we have our three main options when it comes to airway management. We have our OPA, we have our supraglottic airway, and we have the endotracheal tube. Okay, so which one of these is the best to use for our out-of-hospital cardiac arrest patients? Well, there's three things we need to consider when we evaluate these airways. Number one, how well do these devices actually allow us to ventilate our patients, right? Are we able to actually move air in and out of the lungs? Number two, we need to ask, how well does it protect our airway, right? Is it going to protect the airway from aspiration from blood, vomit, secretions from getting into the lungs? Number three, and probably the most important, is how does it affect our chest compression fraction and our CPR quality? We know that CPR quality is vital for a successful outcome for our patients, so we want to make sure that we take that into consideration when it comes to choosing these airways. All right, so let's take a look at what does the evidence say is the best choice in these cases. Okay, the clear winner of question number one, quality of ventilation, is going to be the endotracheal tube. We know we have a sealed off, a direct line for air to pass through the tube into the lungs and back out. So this is going to beat the supraglottic, it's going to beat the OPA. But how about when it comes to airway protection? Okay, the answer for question two, which one protects the airway better, we're going to see that the endotracheal tube is again the best option as it does have a fully secured, sealed off airway. However, it doesn't win by a landslide. We see that the supraglottic actually comes in quite close. If you look at this quote here, this is a quote from a paper that analyzes a lot of studies in regards to out-of-hospital cardiac arrest airway management. We see that in the supraglottic airway device seems to confer a certain degree of airway protection as the rates of regurgitation and aspiration do not significantly differ from those seen with endotracheal tube intubation in the case of out-of-hospital cardiac arrest and are much lower than those reported when a bag valve mask device is used. All right, so it seems like both the supraglottic airway and the endotracheal tube actually do a pretty good job of protecting the airway. Endotracheal tube is going to be the best, the gold standard, but a supraglottic airway seems to do a pretty good job of protecting the airway. All right, how about when it comes to affecting our CPR quality? What is the best in that case? The supraglottic airway seems to be the winner when it comes to CPR quality. The supraglottic can be placed as quickly, just about, as an OPA, and then immediately provides us the ability to provide continuous compressions rather than doing the standard 30 to 2. Let's take a look at this study that was done on immediate placement of an iGel. Okay, so in this study, they had multiple paramedic teams tested just in a drill scenario on a mannequin using OPA placement in the standard 30 to 2 versus immediate iGel placement and continuous compressions. And here was their conclusion. They said that in this simulation study, the immediate insertion of an iGel device led to significantly higher chest compression fraction. This difference can be explained by the ability to immediately provide continuous chest compressions and by the avoidance of interruptions otherwise necessary to provide ventilations when using a BVM device. All right, so which of these three options is the winner? We saw that the endotracheal tube was the winner when it came to effective ventilation and airway protection. And then I'd make the argument that the iGel is the winner when it comes to our management of CPR and high quality CPR and effective chest compression fraction. It's going to be just about as fast to place as the OPA, immediately allow us to go to continuous compressions, and it will be faster to place than the endotracheal tube, and therefore allow us to switch to continuous more quickly. When it comes to the overall consensus, you guys can read these articles for yourself. I'll have them linked for you in the video. There is no specific consensus that one airway is better when it comes to overall outcomes than the other. The one thing we did see is that an advanced airway, an iGel or a supraglottic or an endotracheal tube, has lower aspiration rates or risks than the OPA. But between the three, there is no consensus of what is the best overall for neurological outcomes for our cardiac arrest patients. So my advice to you is, one, make sure you're following your local protocols, follow your medical director. What I teach to the medics in my system is we should place that iGel first line, right? I honestly don't see a reason not to. It's very quick to place it, and usually, in most cases, you have a very good and effective airway right off the bat that allows you to perform continuous compressions. And then if in the case that the iGel is not working to the standard you'd like it to, you're not getting good compliance with it, then in that case, I would switch to the endotracheal tube. Most of the cardiac arrests I run, I place an iGel and it's fully sufficient. I have had some, right, where you place the iGel, you're not getting the compliance you would like with it, and switch to an endotracheal tube. That is fully legitimate technique, right? But just make sure there's good clinical thinking in your decisions with your airway management. Understand that the iGel, while I think we all as paramedics like to intubate, the iGel is very effective, can be placed very quickly, and I think is a very good option. We should be making all of our decisions in a patient-centered way in order to give them the best chance possible. All right. So I know that doesn't fully answer the question of which one's best, but I hope it gives you some insight that while there's no overall evidence that one is better than the other, there's some practical reasons why I think the placement of a supraglottic or an iGel right off the bat and then switch to an endotracheal tube if needed, right? Big emphasis on if needed, not always, but using that approach is going to help us have higher chest compression fraction as well as good ventilation and good airway protection for our patients. Okay guys, my name is Luke Brennan. This is Paramedic Crash Course. Thank you so much for watching. If you enjoyed today's video and found it helpful, please like and subscribe. That very much helps our channel. All right, thank you guys. Have a great day.